Hi folks, you're with Tacitus, your pushback channel. Thank you for joining this radio live stream. And in this essay, I'd like to talk about universal healthcare. And I've seen quite a few articles and videos running around. Maybe it's a bit of a thing at the moment, I don't know, but it seems to be very poorly understood, if understood at all, by particularly people in the United States or any country that doesn't have what purports to be a universal healthcare scheme. Now, I should just disclose, I'm one of the ones that believes that a universal healthcare system is a good thing. As with all sort of government-run systems, it depends on how it's run and how it's managed and the ideologies that are applied to it and so on. So, if I look at the healthcare system in Australia, that's gone through sort of some twists and turns. It's running at a massive loss. So no matter how much they jack up the rates that through the taxation system, no matter how much they put it up, and they're constantly tinkering with it, it's always running at a massive loss. The demand for services far exceeds the even revenue neutral supply. Now, it's got significantly worse since the mass migration binge, the globalist forced mass migration binge began. So because we have a lot of third world peasants in here now and people are being let in who have serious disabilities, serious health issues, and they're all sort of falling onto the health system desperately, and you can go into emergency rooms in hospitals, and in some of the hospitals in Sydney, and it's just chaotic. Their bodies peeling off in all directions, just heaving, and there's very few people who speak English. They're waiting for interpreters, and it's just chaos. And also, a lot of the staff now in the hospitals are people from the third world. Why and how, and for what purpose and reason they're giving them jobs is beyond me. It's whenever the mass migration occurs, the governments that are encouraging and aiding and abetting the mass migration, they've got to give these illiterate peasants jobs somewhere, so they give them government jobs, and they just again lower the standards and lower the standards and lower the standards. So it's not unusual to be talking to an admissions officer in a medical establishment, and they can barely speak a word of English, and they've got they can't use the computer software. They just haven't got a clue, no idea what they're doing. So there are certain sort of side effects of badly managing a national health scheme, but I think the concept is good, and I think the idea is good if it's kept to the citizens rather than sort of extended to people in the mass migration pool. Then it can still be workable. Now, it may be very close to being revenue neutral or not. There's issues around that. But really, once you go down the universal healthcare side of things or pathway, you're looking at rationing things. There just isn't enough to go around to the people that want it. So you have to start rationing it, and the rationing can take various forms. Unlike, say, in the United States, if you can afford it, then you can get the very best healthcare available in the world if you can pay for it. Now, in Australia, there's a national health scheme which runs parallel to a private health scheme. So if you want your choice of hospital, your choice of specialist doctor, say you're getting some sort of an operation, something like that, heart surgery, I don't know, anything, then you can pick your doctor, and the very best surgeons have 90% of their work done in private fee-paying hospitals. And the difference is huge. The hospital may charge $15,000 for a procedure if you've got private health insurance, whereas that same procedure, if the government's paying it, maybe $3,000. So if the doctor's going to get $7,500 for one procedure or $1,500 for another. Now, if you're a doctor who's got the huge mortgage and the waterfront property and the top of the range, Merc or whatever in the driveway, and the wife that expects the annual big diamond ring or something like then you need the $7,500 procedure. So the very best surgeons and medical practitioners stick very much to the fee-paying hospitals and the fee-paying system, and they'll do work which they regard as being tantamount to pro bono because of this much smaller fee that they get when the government's paying it. Now this means that, this rationing means that two things. It means that if somebody, there's a lady down the road, or we know this lady, and she's she's corpulent. She weighs nearly 150 kilograms or over 300 pounds, and she's maybe 170 centimeters tall, 5'7", that sort of thing. So she needs a knee and a hip replacement, and remember it's a free scheme, and she's a pensioner as well, so she fully qualifies for the free medical care. But they've said, look, we're not going to do the procedure on you until you get your weight down to below 200 pounds. Now, the argument is, quite reasonable, by the way, is that if we can do the hip and knee replacement, that's no problem. But because of your weight, you're going to be back in hospital within 6 months, wanting another procedure. So the issue here isn't simply that your knee and your hip have gone, but you need to reduce your weight to a point so when we do the operation, that it will be a success, not only at the time of the operation, but a success in terms of you going forward, so that in the years to come, you'll get good use out of that knee and that hip. So now she wasn't happy about this. She thought, well, they should and she's telling me about this as she's munching on a big slice of chocolate cake. So she said, oh, this, she doesn't like it. I've paid my taxes and I want this service. Why won't they give it to me? And I see her point, by the way, but equally I see their point that why perform a procedure that is unlikely to be useful to the patient? Why not try to create a situation where the procedure will be effective and useful to the patient in the future? So I get that. And if I was the guy doing the rationing, I would probably do something similar. Now, there are other sides as well that say there are two people wanting a heart procedure or minor heart procedure, like inserting a stent or something like that. Now, one person's 80 years old and in poor health, and the other person's 55 years old and in much better health. They're younger and fitter, and they're fairly slim, and all that sort of stuff. So they doesn't smoke and doesn't drink. So they can look at that person and say, the 55-year-old, and say, well, that's going to be money well spent there. So let's do the procedure on the 55-year-old, and we'll just try and manage the 80-year-old's issues with additional drugs, rather than going through an expensive procedure. So there's that. Again, if I was the guy doing the rationing, I would probably make a decision more or less similar to that. If you're going to put your resources anywhere, put it where it's most likely to be of benefit, not only to the individual, but to the community. The 55-year-old's going to keep on working at their job and that sort of stuff. Their youngest kid still isn't through college, so they'll be there to help them. So in terms of the social value of things, I'd do it that way. So those are the examples of the forms of rationing that take place. Now, other forms of rationing are if someone's suspected as having a particular malady, then if they're a fee-paying patient, they'll be put on straight away to the gold standard of examination and investigation. So that they think, well, you might have, I don't know, gallstones or whatever it might be. Then they put the best quality testing process, or they put that patient in the best quality testing process because they're a fee paying patient. However, if it's a national health scheme patient, then they'll do them on the very cheapest investigative practice or analysis. And if they don't get a result there, then they'll bump them up. They may bump them through the whole process up to the same one that the fee-paying patient had, but they start at the very cheapest. So also you're looking at where the aggravation of the process when you're in a national health scheme can itself be a withering experience where you have to go through so many different appointments with specialists that may be many miles away. So you've got the constant travel, the making, every time you go and have one of these appointments, you have to go back to the general practitioner, then you have to go back to the specialist, then back to the general practitioner, and so on. Well, you can bypass some of this if you're a fee-paying patient. So the national health scheme, I think, is a good thing, but it does and will inevitably involve various forms and types of rationing. And if you happen to be in the situation where they think you're not of sufficient social value to warrant the investment of limited resources, then you won't get it. And the national health scheme or not. Now, the national health scheme is you get to see the doctor, you might get to see the specialist, and you don't have to pay it. But the actual service that you're going to require, the operation or the procedure, you won't get that. So that's how, just a snapshot of how, some examples of how the rationing can take place. But I think it's a good thing to have. People will tend to delay medical procedures if they have to pay full tote for it. And there are various medical practices around Sydney where you can go in as a national health scheme patient, but you have to pay an additional amount. You've got to pay another $25 or $30 for a basic consultation, and if they do anything else, you have to pay extra again. So if they say, well, let's test your heart rate or something like that, they'll plug you in some little machine, and it's another $35. So you can walk out of there only having had a basic consultation. You can still be out of pocket $100. So now for older people, that if you've got to pay $100 and you're going to the doctor every week, that starts to add up a bit. For younger people like me that go rarely to see the doctor, then it's no great shakes. But the other benefit of fee-paying medical practice, you go that much higher quality staff, much higher quality, and if the people on the front desk, you don't get the snot-nosed, tooty type girls that you get or women that you get in the government-run places. So much higher quality staff, better quality doctors, I think, as well. And you also, when you go in there, you don't have a waiting room that's absolutely full of people that can't speak English and they're trying to get a free ride. So there's that consideration that comes with, again, fee paying and paying extra. Now, the Australian government has tried to do something to stop people going in for consultations because they've got mental problems or psychological problems. They just like the idea that someone paying them attention and asking them, how are you, and what else can I do for you. They love that, so they need that sort of that feeling of being part of the community or something that they don't have or can't achieve through other means. So you get waiting rooms that are clogged up with people that actually don't have any problems. They just want the attention. So the Australian government's tried a number of times to introduce what's called a co-payment, so that you go and see the doctor and you've got to pay $5 or something, and that would be a disincentive to time wasters. I mean, that was the view that the government took. So that would cut down more than a third. This is even before the mass migration. That would cut down a third of the time wasters. or cut down a third of the people who they believe were time wasters, and that would free up doctors. Doctors weren't necessarily in support of this because it means they would see less patients, so they would get paid less. And in some of the medical practices where it's only National Health Scheme patients, the doctors are just on the go all the time. They could see between 30 and 50 patients a day, and so that's even for a doctor fresh out of medical school, that's they're making $600 a day on approximately on that basis. So has National Health Schemes got its problems? Sure, it has, but I think it's a good thing. Now, a final thing I'll mention with National Health Schemes, when it's government controlled rather than privately controlled, is that the government has created a vast bureaucracy, managerial bureaucracy, with some very well-paid jobs in there. Now, it's not a job where anyone has to do anything. It's just like a sinecure or a stipend or something like that. So it's where people are given, political friends, political relatives, mistresses. It's part of the government patronage machine. So they give all these people, and there are thousands of them, these very well-paid jobs, 6, 7, 10 times the national average wage, for people who do nothing, and they sit there soaking up all this money just because they've got good political connections. Now, that money could be put into patient care and more equipment to be in hospitals, all that sort of stuff. But it goes into the hundreds of millions of dollars that's spent on the patronage machine. And any bureaucracy that the government has control of will be inevitably used for patronage and distribution of patronage. And the health system, when it's a national health scheme, is no different. And we see it in Australia and even more so in Britain. And that's obviously a huge waste of valuable resources. You've been a Tacitus today, your Pushback channel. Thank you for listening.